thank you and thank Harrisburg University for having us. This is such an important topic and such a critical and important time in our country and certainly in our region, particularly in the healthcare sector. Jay, I am the founder and CEO of Metaplan Connect, and we are involved in healthcare financing. We work with employers, with individuals and employees to get their health insurance coverage and other things to help protect them as they turn 65. We are focused primarily on Medicare beneficiaries. So we have a lot of different constituencies, including the beneficiary, the employer. We work with CMS, with the federal government, and we work with the insurance carriers, a number of the insurance carriers. And this pandemic has had a dramatic impact on how we do business and what we've had to do to respond to make sure that people continue to get the coverage they need and are able to finance their health care. And as you can imagine, people were pretty stressed out during these times as to whether things would get paid for or not and so forth. But, you know, my role has changed dramatically. I've gone from being the CEO to, frankly, the Chief Communications Officer, because this pandemic has required tremendous communication, and we've had to learn how to do it, you know, online and by phone and through all means other than face-to-face. So constant, frequent, and clear communication has been the most important thing during this time frame.
So same question to you, Nirmal. A little bit about, you know, your role, your background, and how it has changed since the.
Sure. First of all, again, thank you to the Harrisburg University, and thank you to you for hosting this session, which I hope will be informative. My background is I'm a physician with interestingly with an infectious disease background. I'm trained in infectious diseases. So you know, this was in many ways, when the pandemic hit, this was sort of a calling back to the clinical roots of what I enjoy doing the most, which is learn and in the past practice infectious diseases. So I think it was extremely helpful to have that sort of a background. And in my past life, I had done numerous things related to infectious diseases, including epidemic investigations and so on and so forth. So it was sort of a return to some semblance of content expertise, I guess, in many ways. So my current role over the last several years, I'm the System Chief Medical Officer for Mount Nittany Health in State College, Pennsylvania. And as you know, that's it's a very interesting time up there in State College, you know, right now, with students returning to the university literally, you know, today and tomorrow. So we are at the center of attempting to figure out and plan for the possibility that there might be either pockets of spread and so on and so forth. So in my role, I oversee all of clinical operations across our system. We're about a 250-bed hospital. And in addition to being a hospital, we are the only hospital in town. And also, we have numerous clinics across the area, you know, upwards of 20 to 25 clinics and ambulatory situations. So it's an integrated health system up in State College with a tremendous opportunity to change the healthcare of people around us. My role, you know, as both the Chief Medical Officer and otherwise, almost completely changed since the pandemic began. I was an interesting point in my life at the time when I had actually just made a request to go part-time prior to the pandemic, and was planning to really be able to get my feet up and have a good time for a while after having worked pretty hard. Needless to say, I think it's a dream at this point. But so I came back to become full-time, needless to say, to help with the pandemic. And my role changed to pretty much managing the pandemic, in which was a combination of disaster preparedness and planning, as well as from an infectious disease spread perspective, becoming part epidemiologist, part infectious disease physician, part consultant, and part just a content matter expert on COVID-19. So it completely changed how I both in terms of time commitment, in terms of what I was expected to do, and not just expected, but willingly jumped in and have quite honestly been very thankful that I was able to contribute in a way that is very purpose driven.
So, well, thanks again. And so this is really interesting because you both have really different perspectives within the healthcare sector itself. But one of the I'm an engineer by training, and we used to joke that in any party, if there is a doctor, he or she is the one who gets random questions like, hey, I have a thing on my knee, can you take a look? Nobody asks anybody else this question, right? And I have seen in the pandemic, as soon as even I do, and I think most people do, like you run into somebody who says, I'm the CEO of such and such healthcare, and then the immediate question is, so can you tell us when this is going to end? What is so we keep hearing about all this terminology like herd immunity, vaccines, all these different things. So from your perspective, what are you seeing? What's your insight into what the resolution would be, or at least how you see it? Michael, you want to?
Well, yeah, I'll jump in, but I would certainly defer to Dr. Joshi, and also I want to compliment him and all the heroic efforts of all the providers. What they've done over the last 5-6 months is remarkable. So, Dr. Joshi, my compliments to you and all the other physicians and nurses and healthcare professionals. You guys have done an amazing job. But first of all, the constituency that I work with is mainly older people, more vulnerable people. And I can tell you they're taking this very, very seriously. It is changing the way they live their life, frankly. They're certainly not going out of the house as much. They are having to make changes to do more things online, over the phone, etc. This is a population that heretofore did more things face-to-face, really worked more with interpersonal interaction, and now have had to get, buy things, get health care virtually, things like that. So they're taking it very seriously. I think most of the people that I talk to believe this is going to go on for a while. We see this well into next year. We're all hopeful of a vaccine and more improved treatments. So we think that'll tamp things down a little bit going into next spring and summer. But we're all preparing for another year to 18 months of really hunkering down and doing all the things the CDC is recommending, wearing masks, staying out of crowds, social distancing, and, the frequent hand washing. I haven't washed my hands so much in my whole life. So, I can tell you the population I work with is taking it seriously and all believe this is going to go on for a while.
Wow, that's kind of a reality check. So Nirmal, you kind of concur?
I guess a couple of thoughts. I guess whenever you see people or even experts talking about it, about COVID-19 in the media, you often hear, because that's worthy of news, you often hear dramatic predictions in one direction or another. And I keep telling people that as a content expert, we get humbled over time by how many times we're wrong in what we believe might be when we try to crystal ball. The way I'm looking at it is, given the information that we currently have, honestly, I don't know whether this pandemic will end in a month or it'll end in 6 months or in 12 months or whatever. What I do know is that what is highly likely, given what we are seeing up until this point, is that it will not be a light switch being turned on or off. It'll be a series of dimmer switches that will go on or off, right? And in this case, what we are seeing is, for sure, there will be these dimmer switches. The light will begin to go dim slowly over time, as we are seeing. There'll be some brush fires along the way. But so that's one thing. How long that will take is anyone's guess. I think most people believe that with the onset or the availability of the vaccine, and with us following or not following, depending on the areas, basic public health measures, the three big ones that we talk all the time, hand washing, masks, social distancing. The extent of which to which we can follow those and the advent of the vaccine, I think will cause the dimming of the light, if you will, over the course of the next 12 months. So that's one thing. Maybe even 8 to 9 months, given where we are. We're about almost into the fall right now. And then with the flu season, depending how that plays out, and then with the vaccine, at least potentially being available in the early part of the year, all that put together, and then appropriate public health in terms of pushing the vaccine out and getting people adequately vaccinated, all of that. Put all of that together, and you're talking 6 to 9 months just for that alone, right? So that's one part. The other part that people are beginning to realize is that this disease is, when it started, we were treating it like we treat the flu, or like we treated the first SARS or the MERS epidemic, right? We were treating them as infectious diseases. We were saying it comes with a bang and it goes with a bang, and it's done. This is very different though. What we're finding is that unlike the SARS, the previous SARS, SARS-CoV-2 is behaving very differently. A, it is staying longer. B, that it's behaving not only as an infectious disease, it's also behaving as, in many instances, more of a chronic disease. And some people are beginning to talk about the fact that the virus is simply like the inciting agent that causes that initial insult. But then following that, the body is left with a whole slew of consequences that go well past the effect of the infection. So as an example, in many hospitals now, what they are beginning to do is they're beginning to discharge people on blood thinners, because if one of the effects of the virus and one of the reasons for the high mortality has been heart problems, cardiomyopathies and myocarditis and so on and so forth, which is the result of increased blood clotting. I'm just using that as an example to illustrate that more and more data is coming out that this virus is not just an infectious disease, but it's likely to become more of a chronic disease after this acute stuff begins to go down. So we'll begin to see longer term consequences on the lungs. For example, people are now saying, pulmonary experts are now saying that what they saw acutely in the lungs are what we used to see in interstitial lung disease over a period of 10 years. That's happening within 2 or 3 weeks. So that consequence is not going to go away. It's going to stay with that individual. So back to your question, I think 2 things. One is it will be a series of dimmer switches as they go down with the disease itself. And then we'll be left with a whole bunch of people with what I believe will be some consequence. That's still evolving, and we will learn more about it, whether it's a bad heart, a bad lung, or a bad vasculature in some way. But all of that are going to stay on so that there'll be a long-term effect, not to mention the ability or the potential for the virus to then have a true second wave at some point in the next 12 to 16 months, for example. So I'll pause there to hopefully that gives you a flavor from an infectious disease standpoint, how we are seeing the evolution of the virus.
Yeah, so that's certainly helpful, and I will circle back because I'm not going to let you go with that. We're trying to figure out, since you are the physician in the mix, trying to get a little more down to the comfort of the audience. But so I just saw Janine has joined, so I want to welcome her. And I know you have other things going on, and I really, really appreciate you trying to make time to join the panel. And before you joined, I was telling everybody that this is probably the most interesting and exciting panel for a lot of us who have no idea where this thing is going. And so as soon as we hear anybody who works in the healthcare sector, we are like, okay, do you have an answer to tell us exactly what date we can all go back to work, or where we are going? So with that, the first thing I would like to, maybe you can give us a little bit background about your role and how it has changed since the pandemic.
Good afternoon, everyone. Sorry I was a little late joining you. I am pleased and honored to be with this panel of panelists today. So Hamilton Health Center, as many of you may know, is a federally qualified health center here in the city of Harrisburg. But over the last couple of years, we've also expanded into 2 rural areas of the South Central PA. We are an essential provider, so we have been open since the very beginning of the pandemic. We've had to adjust very quickly to, one, we pivoted to telehealth services, which has been a lifesaver for us in staying connected to our patients. The other is trying to provide the safety and of our own employees, which we have almost 300 people that work for us. So we have our direct line employees, the doctors, the dentists, the nurses, all of that staff still working every day, but the social service staff, those that we could, we have them working remotely. So we've had to adjust in terms of policies and procedures, and as well as the way in which we are serving our population. We've been fortunate to have some federal funds been awarded to us, and we're now doing community testing. We believe that in order for us to really understand what's happening in our communities, we have to have ample testing. And as many of you have been hearing on the news over these last several months, there hasn't been enough testing. And once there is testing, it's how quickly can we get the results back. So I think the hospital systems in particular stepped out very quickly, got testing going for those who were symptomatic. But our approach is let's get it into the communities that are at highest risk. And as you have heard on the news and hear from the doctors and scientists, minority populations are at greatest risk. And our population is primarily minority. And so the testing that we're doing is mobile. We're moving it all around the city, within the city. The hospitals have taken care, I'll call it the periphery of the city. Ours is for symptomatic and asymptomatic. And I think that's the first step in us getting a good handle on this disease, knowing who has it, giving them instructions on what to do. And then quite honestly, everyone's waiting for that vaccine to come out, which we don't expect to happen until, into 2021. And we're getting ready to go into flu season. So we're gearing up for flu. We're going to be doing immunizations in our mobile units, as well as the COVID testing, so we can try to keep the community as safe as possible.
Well, so thanks, Janine. And, so now we have brought a different perspective also into the mix, because you mentioned about the minority population mostly impacted. So, Michael, you mentioned the aging population, and Nirmal just talked about, how the indications are that this is becoming almost like a chronic disease from an infectious disease, or there are, problems that seems to be left behind. And I think the most vulnerable would be the aging population. So what's new, or, given that there is so much data and this has been going on for quite some time, what are some of the changes in how those patients deal with this, how they are, insulated, or, what's new?
Well, I think from my perspective, we see several things, and I think Janine mentioned one of them. The senior population has had to get accustomed to virtual healthcare visits. That's not been easy for a lot of people. I think a lot of them are more comfortable just doing something over the phone, but those who do use a computer, will try to use the computer. Again, that population would much rather go face to face. So as Janine said, testing has been critical, and, the ability for healthcare centers like the Hamilton Health Center or other healthcare providers to provide a safe environment for these seniors to go into, because a lot of them feel they need to go in to get the care. The other thing with our population is many of them have at least 1 or 2 chronic conditions, and that's been a real challenge to continue to manage those conditions while trying to avoid COVID. Just something as simple as getting groceries, can be a huge risk for someone with multiple chronic conditions. So, the senior population has had to make a lot of changes. And frankly, I know a lot of our clients have called and they have just not had things done. they're pushing things off, and that's not great either, but it's been the reality. I hate to say it. So, a lot of them are waiting to get things done. I just talked to a lady yesterday that was supposed to have her hip replaced 3 months ago and has been pushing that off and is now in more pain. And so this has really created a lot of hardships for this vulnerable population, the senior population.
So, which brings me to Nirmal, a follow-up question, because as we just touched on, the patients that are more vulnerable, right, the minorities and the aged population, is there something they can do? And then I also have this whole question of, because you keep hearing about people have or contracted it, but they don't show any symptoms. And so we worry about, like, my son is in college and they just decided to go in Northern Virginia, and so they decided to go full in-person class. And I have a mom who is like 75. So does he, if he carries and he's not tested and he comes home, so how do you even know if somebody is carrying it, or what's the risks there? And how can you avoid some of these things? I understand about the washing and the mask.
Yeah, so it's been very interesting. I think what Janine is mentioning is at the heart of the pandemic. Frankly, the disproportionate occurrence or prevalence in communities that are vulnerable for a variety of reasons, not just this, but particularly Hispanic communities and African American communities. And there are a variety of reasons why, and some of them sadly are the same that cause them to be vulnerable for other diseases as well. So whether it be the ability or lack thereof to maintain social distancing in households, right? We all know what those reasons are, and they're the same exact reasons why. I don't think there has been anything genetic or otherwise that has been found to be at the heart of why the disease disproportionately targets Hispanic communities or African American communities. It has been much more the epidemiologic risk factors out there that are no different than what we've sadly known, what we have called disparities in care, right? They're the same things, and I say sadly because we've known this for a while, and this when the pandemic hit across the world, is that some of those same factors lend themselves to be predictors of a higher incidence and prevalence, and also a predictor of a poor outcome. Because with the poor outcome, it is the same communities who also have a higher incidence of diabetes, a higher incidence of being overweight, a higher incidence of having hypertension, what we have historically lumped together as comorbidities. So it's so the most vulnerable among us get then disproportionately hit. And many of the things that we talk about for preventive measures are the hardest to do for those same reasons with these same groups of individuals. It's hard enough when you're living in a multi-generational home that is 3,000 or 3,500 square feet. It's another thing when you're living in a multi-generational home with multiple players of different ages being in a house that's maybe 900 square feet, right? So you can just imagine how hard it is. So I always say to people, for us, it's easy sitting in our offices to say, social distance, hand wash, put on your masks. They're the hardest things to do when you actually play it out in a household, when you actually begin to see the dynamic that is practically unavoidable, right? When you come that close, it's very, very hard. What we've said to people is from a public health standpoint, which is why we make such a big deal of masks, because there are many other things you simply cannot avoid coming close in a home that's cramped. I can't avoid that. What I can avoid is, or what I can do is wear a mask. And the mask, I mean, all of you have seen the same data that I have, and I've just researched it a little bit more by looking at it more closely. But the fact of the matter is that when there is a barrier, a physical barrier, the odds of that those droplets being able to get out, even in tighter situations, is lower. So I have always said, even when my son gets home, and kids are simply not, amenable to any of the basic measures that we talk about. Even my kid, who is no longer a kid, he's a physician himself, he's a resident now. When he comes home, he has to be reminded to wear a mask close to my mom. We're a multi-generational home. My mom is 88 years old with multiple comorbidities. I have to remind him to do that. He just walks in like there is nothing going on, despite the fact that he is extremely educated. So I can only imagine what happens in tighter situations where it's hard to social distance. But I think we need to keep drilling actively at the same three basic infection control practices, of which I personally have always believed the one that you can perhaps more practically follow, even in tight spaces, is masking.
So Janine, one of the follow-up questions, because as Nirmal just mentioned, the tight spaces, the challenges, but then when you talk about the minority community, the economic challenges also is part of it. So part of this whole conversation, the reason we call it Conversations in Innovation is it kind of ties into what are some of the innovations and what are some of the impacts beyond the direct health, right? So when you talk about a lot of the minority community, or people whose jobs depend on, like the restaurant or the waiters and people like that, it's on one side, it's easy to say, okay, you wear masks and all that, but then they have to get out and do their job. And the restaurants and the industry itself is kind of, closed, or, there is no timeline for when these will open. So there seems to be a lot of, on one side, the healthcare related education, but then also the economic impact. So what are you seeing out there within that community? And is there something specific that you do in educating them about, how to be aware of,
The points being made have been excellent in that it's all about education and making this the norm. I used the story about in the past going out, and when you would see someone wearing a mask, you'd say, oh, do they have a disease? Is something wrong with them? And now we go out, and if we see people not wearing a mask, you're saying, what is wrong with them? I understand, we all have rights, and it's our right to wear a mask or not to wear a mask. But the reality is we can't be so selfish as to only think about ourselves. We need to think about the environment around us. And, I've been looking around where I've been grocery shopping. I've started to go to some of the restaurants. Whenever I can, I eat outside because we know if you can be in an outside environment, it's better than being inside. But wearing that mask wherever we go. And, when you get to those restaurants, because of the mandate to social distance, the tables are further apart. They allow you to have your mask off at your table because it's assumed that the people around you are people you are comfortable and knowledgeable of. And I think all of these are important. And the role that all of us have to play is to educate, to make this the new norm. I think we're going to be wearing masks for a long time to come. And we're now partnering with the faith-based community to educate their congregations about this kind of social distancing, mask wearing, washing hands. I mean, those are the three things that we need to continue to take whatever venues that we have access to and just begin to educate. It's going to be almost like what's happened with smoking, where smoking is no longer allowable. And when you see people smoking, it's, you frown on it. I can remember when it was totally acceptable. Seatbelts, helmets, our society had to come around to this public health way of thinking. And it's only then that we're really going to get a handle on all these. And, Normal is quite right about the social distancing and how people live, because everyone doesn't have the opportunity to have a lot of space in their homes. That's the chronic conditions people have, And the lack of ability to social distance is a huge reason why we're seeing the disproportionate share of this disease in minority populations. You know, when people are, it's in their culture that you live with older people, you know, you bring your families together. That's just the norm. And so it makes it much, much harder to control the spread of that disease in those kinds of environments. So, you know, education, we talk about our healthcare system really has not been very focused on prevention. We haven't, you know, we call ourselves a healthcare system, but really in reality, it's always been a treatment system. We need to really spin this over to the prevention side. We need to think about it as a public health condition. And in my environment, in our healthcare center, you know, we are doing social distancing. We've spread out our exam room space. We take temperatures of everyone coming in. We ask the questions that everyone now is used to being asked. I'm at the hospital with my husband right now, and they only allow one person to be able to come in and see that person, when before we could, you know, have the family. So it's getting used to this new norm. Two, as you know, was brought out earlier with the elderly population, they're not used to technology. But the one thing this disease has done is to make us all think differently. We have to innovate. The technology is going to be a means for us to reach the most vulnerable of our population and try to make it as easy for them to link into a healthcare provider as possible. We're even, from an innovation standpoint, talking about doing point of care, meaning you can come to our mobile unit to get your blood pressure checked, to get your A1C checked, because doctors are saying, how do I do telehealth when I need to touch the person, when I need to get the vitals on a person? So, you know, from our aspect, and I think in the healthcare sector in general, we all need to start thinking about how do we do those vital things that we need to do as healthcare providers, but in a safe way for the population, because the elderly have not been the most agreeable to accepting telehealth, yet they are very afraid to come into a center to get their healthcare needs. So they are delaying their physicals. They are delaying coming in and getting their diabetics getting their A1 checked. We've got to figure out ways to make it safe for them, as well as getting the information that healthcare providers need to keep them safe and healthy.
Yeah, so why, you know, like I said in the beginning, this is one of the, I think, the most expected kind of a panel where, you know, people have a lot of questions. So since we will quickly run out of time, I think each of you have at least these questions. So Michael, one of the questions that came up is, due to the changes in utilization patterns, how has the cost of care changed? Are you seeing anything? And, you know, either of Nirmal or Janine, if you want to add anything.
Yeah, Jay, that's a great question. And certainly we've seen a large increase in utilization of services for COVID-related, for testing and treatment, COVID-related illness. But on the other hand, we've seen a decrease in utilization for any type of elective procedures, elective surgeries, things like that, which have offset, you know, the costs of COVID. So, you know, I would say we're kind of in neutral relative to the cost, if not slightly lower than we were a year ago. However, I do see increases coming up in 2021 because people are going to need to get the services that they haven't been getting. There's some pent-up demand. And so we're going to see, I believe, increased utilization going into 2021. Also, to their credit, many of the insurance companies, and we worked with a lot of these companies, have agreed to pay the cost of the testing and treatment for COVID so that people could get the care they needed and it wasn't out of pocket. And, you know, to Janine's point about education, and just as an aside, by the way, I want to say Janine Peterson is a titan of healthcare in the Harrisburg area and deserves tremendous credit for what she's done with Hamilton Health Center and the access they're providing. So my hat is off to Janine Peterson. I have to say that out loud. That's critically important. But, we have two of my team members are Hispanic, and we have done education sessions in Lebanon and Lancaster and Reading, and we're working on a couple in the Harrisburg area. One of the problems of healthcare disparities, and we've all known it, I've been in healthcare financing for years, we know that minority populations are not getting the healthcare that they need, partly because they don't have access, partly because of the cost to this question. And, there are a lot of programs to be able to finance healthcare. And part of it, going back to Janine's comment, is education. So we are focused, and we have a lot of minority clients, and we are focused on getting them the education and finding them the financing and the coverage that they need so that the cost is not a barrier to getting care, and they can get the tests and get the treatment and frankly work on the illness burden that they carry, because so many of them do have chronic conditions because they haven't been getting the care they need. So education is critical. But I would say by and large, we are going to see cost increases in healthcare and in utilization, I think, in a fairly significant way in 2021 because of the pent-up demand for services that have been gone unfilled during this pandemic. And I'd be anxious to hear Normal and Janine's comments on that.
From a cost perspective, as you might imagine, there was practically no clinical activity or very little. We were about half or less of our volumes at the hospital, and that was true of the hospitals across the nation in some way, shape, or form, other than if you were in a literal hotspot at the time, which was different. Those were relatively, thank God for that, relatively few in number, relatively speaking. Most hospitals have struggled because, needless to say, from a purely business standpoint, costs went up tremendously in putting systems in place for surge planning, but volume and revenue completely declined. So you can do the math, what was happening with most systems, particularly hospital systems, that they were disproportionately hit. We ended up at State College, we ended up significantly downsizing staffing, everything else to be able to keep up with the diminished demand at the time. Very interestingly, though, I think while it's fair to assume that there will be a resurgence and a bounce back of volume at some point in the future from pent-up demand and what have you, I do think that hospital systems, for example, who have taken the hit during the pandemic, much of that significant hit, particularly for small to medium-sized health systems, much of that hit will not be recoverable in many ways. Even to this date, we are not fully at 100% of volume, even though we should be. Various reasons for that. Part of it is the hesitation on the part of the community members, particularly older community members, to come back and seek healthcare and so on and so forth. And interestingly, there have been a couple of publications of late in peer-reviewed journals in medicine that have actually looked at some of the reasons why what we are calling a pent-up demand may or may not happen. So it's open to question how much of that might actually happen purely from a demand perspective. However, based on what I said earlier, I do suspect that healthcare utilization, even related to COVID, is likely to go up because there will be consequences of among people who survive. Those who sadly, succumb to the disease are no longer with us, but those who stay, it'll become part of a chronic disease consequence to the lungs, to the heart, to other things that we're just beginning to see that tip of the iceberg. And I suspect that will play a predominant role going forward, quite honestly, not knowing the other part as to whether or not the pent-up demand will come back or not for a hip that's been waiting in the wings and that kind of thing. I don't know. But on the testing front, on the masking front, the short answer is, I think with masking, you are making choices of the best way to be able to live a life without completely stopping to live. You're still doing safety measures, right? It's really a compromise. As they say, there are two curves, one of safety and the other is convenience. And you can make something completely safe, but make it impossible to live, right? And that's the answer to that question. Wearing a mask at most times when you can is a good idea. When you're sitting down and eating, the supposed logic is that the restaurants, when I've gone to restaurants, lately 1 or 2 times, is that they have separated out the tables. They have occupancy that's less than 100%. And supposedly what that does is because of at least one of the parties, in this case, someone who's waiting on you is wearing a mask. So the benefit is that you are not in direct exposure other than your own family unit that's sitting at the table. That's the logic. Not perfect, but that's better than not wearing a mask at all, even going in. So I hope that answers that question.
Yeah, thanks. It's again, like I said, we're running fast out of time, and the questions are just popping up quite a lot. So this is Janine. I think this is specifically to you because I think you mentioned about the testing. So what test methods are applied or used for mobile testing, and are you seeing different?
So at this point, we are actually seeing the use of the nasal swabs. That is the most widely used, and it has been we're telling people 7 to 10 days to get them back. And that's because of the volume. When the amount of testing went up, the national labs, like LabCorp and Quest, were not able to keep up with that demand to turn it around. We just did a testing program this past weekend. Those test results are back. Quest is now telling us that they can get those back in a matter of 3 days. So they've been improving their processes as well along the way, as well as having more abundance of testing. What we're really doing, there are some rapid tests that are available now. We are in the ordering of those kinds of equipment and that type of test. But there's a backlog. Everybody is trying to get hold of the same supplies, just like we experienced with the PPE in the very beginning. That's what we're seeing with testing supplies. So we know there's a rapid test. We know there's a saliva test. So the testing processes are improving. The labs are improving the turnaround time. And, that will help us all as we continue to get people used to and availability of testing out there. And clearly we need to test those who aren't just symptomatic. And in the beginning, because of the limited supplies, that's what the hospitals had to do. Rite Aid and CVS have jumped in. They're trying to test primarily the symptomatics, but more testing supplies we can get, the more that will open up. And the faster the labs now will be able to process and get us those results. In order to get a good handle on it, we need to have rapid results. And if I could just comment really quickly, there's 2 areas that, we focused on healthcare being medical, but the dental services were almost wiped away in the environment, and they're now coming back, and we hear about higher costs dental care because of all the PPE. The one area that didn't get hit in a negative way was behavioral health. The need for behavioral health services has escalated significantly because of the anxiety and, all of that comes with being confined and being concerned. There's just not enough healthcare providers, whether it's medical, dental, behavioral, as people come back into the system or more people try to access, especially with us having to do social distancing, the amount of appointments that a provider can have is less than what it was when we went into this pandemic because of social distancing. So, we compound our issues as we move forward because of all the controls that we need to put in place.
Well, thank you, Janine. So I think we have about maybe 5-7 minutes. So there's a lot of questions. So Michael, one of the questions, I think this probably you can answer this, is how are people using technology and innovation to address physician and nurse and...
Well, clearly virtual health is really I think that's the big innovation right now. I've been in this business for years, and we had we had, touched around the edges of telemedicine, and we worried how we were going to pay for it and if we were going to pay for it and how much, because, was it going to create overutilization and so forth. And we've gotten past all that now with COVID. So now I think telemedicine is really key. It's going to be mainstream. Those people who can and will use a computer, that'll be a little better because you'll be able to see the patient. But even by phone, I think telemedicine is going to be very, very important in terms of innovation. There are a number of other innovations too that are going on as we speak. There's a lot of new home monitoring types of devices and technology that will allow people to be monitored by a physician or by a nurse or by a healthcare professional from their home. One good example is when people have congestive heart failure, for example, they can be monitored when they weigh themselves in the morning. They can be monitored through other devices, and that data goes directly to the provider, because if you have congestive congestive heart failure and you gain a few pounds, that's a bad thing. And the provider needs to know that immediately. They need that feedback. So what we're seeing in addition to telemedicine is the home monitoring things, and that's starting to come fast and furious. And frankly, I don't know that our industry is keeping up in terms of how much do we pay and what do we pay for and what really has value. But I do know that there is going to be a lot more monitoring of people from home, a lot more mobile applications, for diabetics. Normal talked about how COVID is going to manifest itself in the form of more chronic conditions. Well, we're going to have to monitor those people, and it can't be people walking into a physician's office every other day. So we have technology, mobile technology that can do that. And so I think you're going to see a lot more of those types of devices. The issue is, will people get comfortable with it? I know the population we deal with, the senior population, is not as comfortable with these types of devices. And so we're going to have to do better training and get people more comfortable. So the user experience, the user friendliness is going to have to get better. But I see that really as the big next wave of technology application to healthcare.
Sorry, I didn't mean to. So no, I would strongly agree. I think that has been one of them.
So, yeah, go ahead. No, go ahead, because I'm coming to.
Sure. So I'll just follow up on both what Janine said and Mike said earlier, is telehealth has been an absolute godsend from the standpoint of the doctor-patient relationship. If that was not there during the pandemic, it would have been so difficult to be able to do what we were able to do. There was a tremendous uptake of telehealth, and it's music to my ears that, there was some concern that payers might pull that back. I think to a lot of detriment, I believe. I think it'll be wonderful to continue that opportunity, because I know personally that the opportunity to interact with people in whatever way we can is better than not being able to interact with them. So I think that's a huge innovation. Well, it's hardly an innovation. It's been around for 20, 30 years. I think it's coming of age is a better way to put it. So that's one. The comment about physician and nurse burnout, I'd be remiss if I didn't say this. What you see on television, what you see from hotspots and so on, is what people are saying, what physicians and nurses are saying from those hotspots is not burnout. They're saying they're tired, right? They are exhausted, they are tired. The vast majority of physicians who are not in hotspots actually found their purpose in caring for people during this pandemic. And so did people who are in hotspots. So I actually don't think the messaging that I'm getting from our colleagues is not of burnout during the pandemic, has actually been of purpose, of finding their purpose, of being able to say, I know exactly what I need to do when there is a crisis like this, and my skills are actually coming to good use. So there's a difference between being tired, exhausted, and spent at the end of the day, and also getting a tremendous sense of purpose and of what we do and why we went into medicine in the first place. So I think that's important to mention. I will take, I think you said something about a question around a test or a, yeah. So in hospitalized patients, there have been 2 or 3 lines of medications that have been used. Remdesivir has been the most commonly used antiviral agent in the hospital setting. The problem had been its availability. Similar to many hospitals, including ours, we were part of national clinical trials where we would be able to, based on pre-selected criteria, get remdesivir and treat people. So we did treat a handful of people who were pretty sick in the intensive care unit with remdesivir. The other 2 big ones have been obviously monoclonal antibodies, and has been the use of plasma, convalescent plasma. Those are available through the Red Cross. They're not directly available, but they're used through the Red Cross, and those have been used with very encouraging results, frankly. It's been usually a supply issue of how many you can get. And secondly, while they change the course significantly in some people, but more and more people are realizing, to my very early comments, that this disease has more to it than just treating the virus at that point. There are these cytokine storm related things. There are issues of lung damage and heart damage as a result of that. So people are beginning to actually learn some other modalities, including blood thinners, like I said, as an illustrative example, of using things in addition to antiviral treatment, because it's looking like people who do really poorly, by that time, it's like a storm came. The storm is the virus, but the effects that it left behind are far beyond what the virus does. So if you just simply kill the virus at that point, it's done the damage already. So I think that's something that's important to kind of at least make a mention of.
So we're pretty much out of time. So I just wanted to end in a positive note. So so starting with Janine to Michael to Nirmal, kind of, what's the one thing you would say to all these people, who are seeing this, who have heard this, still trying to figure out?
I think the positive thing that I could state today is that our healthcare system has been tested and came through with flying colors. The people that have devoted their careers to healthcare have come through. They've shown up every day. They're on the front line. They're learning about this disease. They're testing, they're giving advice, and had to pivot very, very quickly to a new technology that they had never used before. And so I think that the healthcare system in our region and across this country, the healthcare providers are the true heroes, and we know now for sure that they're going to be here and supporting the populations that they serve, regardless of what the situation is.
Well, I think just there's so much hope. We have the best technology in the world. We have the best medical providers in the world. And even as much as they get maligned, the insurance companies have stepped up and they have paid for the treatment. No one that needs treatment is going without it due to cost. So I would say keep the faith, keep the hope, because we will get through this, and the care is there. There are so many caring providers that are working with people, and they've done a remarkable job, and the healthcare is being financed.
I think it's honestly, whether it be providers or it be the community or it be people who've suffered or people who've lost their lives or families who've been disrupted, or in some instances lost, kids have lost both parents, for example, and so on and so forth. That's the bad news. On the good side, I really think I've seen repeatedly the triumph of what I call the triumph of human spirit. It really is. It's quite fascinating to me. In the middle of despair, some of the best stuff is seen in the middle of despair and desperation. And I've seen that not only in our community, in people, and I've seen that face to face in our providers, right? There was a period of time where many of our providers, currently, to someone else's point, provider burnout rates, physician burnout rates are well into the high 40%, right? And I believe this was a time when all of us as colleagues kind of came together. I can't tell you when I was disaster planning how many of our physicians raised their hand, including one provider who was pregnant, who raised her hand to say, I'll serve on the front lines, right? To me, that's the triumph of, I mean, it's heartwarming to see our providers come to, I've never seen the physician community come together like this, like I've seen with this pandemic. And I believe that that's a testament to, and I'm just using physicians as an example because I interact with them. I'm sure if you ask Janine or Mike or anyone else, they can give you examples of people who rose from that despair and desperation. And I call that really sort of a rise of the human spirit and really coming alive. I can tell you, I have tremendous hope. If there is one thing that struck me, it was that is as to how we have come out as human beings, as people, many of whom have actually found more purpose in life than they ever had in their lives in the face of such a massive challenge that's international, that's to humanity across the board. So I can't tell you how excited I am at seeing that despite the desperation.
So, yeah, so let's end with that note. So thanks again, Michael, Nirmal, Janine, for everything that you're doing. I mean, thanks for joining the panel, but more importantly, finding the time to join this panel and share some of the insights. But more importantly from me, and I'm sure all of the people who are listening in will agree that for everything that you're doing, and what I hope is that I will be able to bring back all of you in a few months when you will be able to say, well, here is more clarity around things. And I'm sure that will be a great way to bring all of you back together. So thanks again. And so we'll just, we wrap up usually by running a video about the center and what we are doing at the center as kind of the last part. It's a plug on, what CIE does every day. So with that, thanks again for all of you, and thanks to the audience.
2001, Harrisburg University has grown again and again. Just last week, the school held a groundbreaking ceremony for its new Health Science Education Center, hotel, and restaurant. The building will allow for an additional 1,000 students there. Another addition to Harrisburg University, the Center for Innovation and Entrepreneurship, or CIE. This will help students start and build companies. Executive Director Jay Mohan is here to tell me more about it. Can you give just a basic description, sir, of what the CIE is? Just elaborate a little for us.
Yes, so the big goal is to get people who have new ideas, innovative ideas, to get them through to the execution and build out companies. So we hope that the next Facebook, the next Google will come from this region. That will be the great dream that I have. So that's kind of the basic idea. So we provide with guidance on strategy, marketing, we give them the infrastructure to build out the new companies. While it's focused on the students, we encourage local entrepreneurs to come in and take advantage of the facility. That's kind of how we're looking at it.
Why do you think this is needed?
Yeah, so if you think about the economy today, people call it gig economy or automated economy. So things are moving rapidly and changing really fast. So that kind of makes people either terrified or excited. So we want people to be excited about the changes and prepare them how to face these new technologies, how to understand artificial intelligence, data analytics, machine learning, or robotics, and create opportunities from them. So if you look at most of the job descriptions these days, you will always see that they are looking for innovative and entrepreneurial people. So that's what we're trying to build here, and that's why I think it's the need of the day.
Let's talk about some of the highlights. Once completed, there's going to be some really cool things going on there. Tell me about those.
Yeah, so we're going to, so Harrisburg University already have like biotech labs. There's so many different features that we have already built. So the idea here is to connect the makerspace, the active learning labs, all of this together. And this becomes like the coordinating center, which will pull in resources and infrastructure from all across HU. So that's kind of how we look at it. Because my job is to create or empower others. So the tagline that we use for this is empowering innovators to build successful ventures. And that's not just a tagline, that's a commitment we make to anybody who comes in. So that's why we try to have that infrastructure in place.
The advantages for students seems obvious, right? But the thing is, this also benefits our region, the Harrisburg region. And can you explain how so?
Yeah, so if you look at, like, everybody says we want to recreate Silicon Valley, but Silicon Valley has its own unique features. But if you look across the region, you have Austin, which has come up really like a whole lot of innovations, a lot of companies. DC, from where I am, there's a whole lot of companies from that region. So if you look at Harrisburg all over, it's most of the regions where these development have happened, it's around a university, a science and technology university that kind of becomes the hub, and there is all these spokes that develop around that. So that's kind of how I look at it. So Harrisburg and the larger region around that will really benefit from all these entrepreneurs that are coming in with new ideas, and it will create jobs and the economy.
It's terrific. And like I was sharing with you, what Harrisburg University is doing is just remarkable here in our area. Thank you for sharing this latest adventure with us. We'll be right back with our second half hour.
Thank you.